Good afternoon, everybody. Welcome to Grand Rounds today. Today, I have the pleasure of introducing Dr. Thomas Serena. Dr. Serena is CEO and medical director of Serena Group Incorporated. He's the president and trustee of the Serena Group Research Foundation. He's past president and fellow of the Association for the Advancement of Wound Care. He also is the emeritus president and master of the American Professional Wound Care Association, past board member of the Wound Healing Society, and also vice president of the International Surgical Wound Complications Advisory Panel. And very kindly has accepted our invitation today to present at Grand Rounds. Title of the presentation is For All the Wounds I've Loved Before. Please join me in welcoming Dr. Serena.
Thank you. Actually, we didn't hook this up. Well, I wonder where that is. Give me 1 second. I'm going to hook the clicker up. All right. Well, as the title says, For All the Wounds I Loved Before, I'm a general and vascular surgeon, as you may have heard, and I started at wound clinics in the 1990s. There were no wound clinics then. And hyperbaric was used for diving and carbon monoxide. So I had a very busy general and vascular practice. And because I'd also had a very confused youth and done plastic surgery as well, everyone thought I was the wound doctor, and apparently I was. So I started my first wound clinic in order to get the smelly patients out of the office. And then I fell in love. I fell in love with the idea of wound healing. And it's really something that we take for granted. Because you cut yourself. I cut myself the other day, with the chopping up tomatoes. I'm not very good in the kitchen. And expect that it's going to heal up in an orderly fashion. And it usually does. But there's a whole world out there that I'm going to share with you this afternoon where patients don't heal. And what do we do as well? We give these patients all kinds of poisons to keep them alive, to help their arthritis, to all the biologics that we use, and they all impede wound healing. So this has become a huge problem. And there we go. All right. So wound care is actually pretty easy. Surgeons do it. So this is on the plantar aspect of the foot. So this is a diabetic foot ulcer. It's like real estate. Location, location, location. You look at the wound, you can pretty much tell the etiology. In fact, our wound care fellows and students that rotate with us, I make them stop at the threshold of the door, look in the room, and I say, what is that? What's your diagnosis? And just by where the wound is, almost always you can tell what it is. This is a diabetic foot ulcer. Actually, then on the side of the leg, in the gator region of the leg, venous leg ulcers. Now, this is a true story. I used to dictate this back when we dictated, and I would say the gator, G-A-T-O-R, region of the leg. And the transcriptionist used to come back and say, it's gait, G-A-I-T, not gait like, alligator. I said, well, please use my spelling, because if it's not in the gator region of the leg, you might get bit, and that's very important because venous ulcers should be mostly on the inside, on the medial gator region of the leg. If they're not, it might not be a venous leg ulcer, and I see a lot of patients who come in with cancers and other things where it wasn't in the gator region of the leg. The provider assumed that it was a venous leg ulcer. What do you think that is? In the gator region of the leg. I actually wrote the code for venous leg ulcer, and the coding gal came back and said, you can't, no, she's 14. Pick something else. I had no idea what it was. But I should have paid a lot more attention, or, I'm a surgeon. We don't take the greatest histories. We're not known for that. So we put her in a compression wrap, this is after she had compression and antibiotics. It looks a lot better now. And then I did a biopsy. The beauty of wound care is if you don't know what it is, it's right there. Just biopsy it. And I'm always trying to get our nurse practitioners that we work with to don't know, biopsy it, don't guess. And 3 days later, the pathologist called me and said, Tom, there's external graphite in this biopsy. I said, what? Yeah, it's pencil. So she came back in for a follow-up visit, and then I looked at it again like this, and I said, What's your football team? The Tigers. Now we know what it is. Every morning in homeroom, she'd take her pencil and she would giving herself a tattoo, not a venous leg ulcer. So pressure ulcers occur over bony prominence, a huge problem in the homebound patients. Right now, we have 192 pressure ulcers on service with our nurse practitioners. That's an enormous amount. And these patients don't do well coming to the wound clinic. They do better. They do much better when they're seen in the home. And this has become a big part of the expansion of wound care into patients' homes and into the nursing facilities. Arterial ulcers occur typically distally on the toes and the feet, the top of the foot, and these are due to inadequate circulation. And that's the 4 basic food groups of wound care. And if you look at the wounds and look where they are, and you're going to be right almost all the time. But once you get good at those, then you'll see all kinds of wounds. These are dehisced surgical wounds. We see a lot of these. This 87-year-old woman was sent to me by one of my buddies who took my position in general surgery when I went into wound care full time, and he said she's got this hernia she's got this wound at the end of this hernia. And in surgery, we call that she's lost the right of domain, which means all of our external organs are on the our internal organs are on the outside. They're now external. So if that becomes a full thickness wound, he says her gut's going to spill out everywhere, and I'll have nowhere to put them back in. So we put on a soft silicone dressing that was just coming out at that time that worked out really well as a covering. And then we went to JCPenney. I think JCPenney's still around. I think they survived the pandemic, maybe not. But and we bought this really stretchy fabric. And my front desk person was a seamstress, so we made her a sling. And with the sling and the foam, she went on to heal, and she died a few years later. Something completely different. Now, had I been smart, I would have patented that sling, and I'd be Lululemon right now, and I wouldn't be here. Sorry. I mentioned cancers. It's another thing, particularly in our southern locations where we consult and work. You have to be careful that there might be cancer present within the wound. Traumatic wounds. And infectious wounds. And this is a patient, a hyperbaric patient. This is a 32-year-old diabetic, had an in-office vasectomy incision like that big. And 2 days later, he had MRSA, necrotizing fasciitis, or in this location, it's oftentimes called Fournier's gangrene. So he did extremely well. Hyperbaric, topical growth factors, and he went on to close nicely. Just in case anyone's thinking about elective sterilization. We do chest wounds. We do a lot of atypical ulcers. Now, this lady thought she had a venous leg ulcer, but she didn't. She has a disease called pyoderma gangrenosum. It starts as tender nodules. Then you see this purple edge. And I always tell the students, if you see the purple edge, you got to think. And then it becomes a necrotic ulcer. And this is another uncommon disease that we see a lot of. So we're going to show you a number of these, and maybe it's just because we have wound clinics that they show up in the wound clinic. And it used to be the dermatologist treated these patients, but most our derms that we work with now are like, oh no, please send it over there, kind of like I did when I began. If you see an ulcer near a stoma, almost always it's pyoderma. This is a COVID wound. It looks like a venous leg ulcer, right? It's in the gator region of the leg, but it's my leg. And why is this a COVID wound? Because during COVID, the kids had nothing to do. So I said, let's make wounds. And so we did. And so I can give you the recipe if you'd like, or it's on YouTube. And you make it's a latex thing. You boil it, and then you make it, and then you let the kids paint it. And they actually used it in our research for measurements and see how accurate the cameras can be at measuring the wounds. Again, not in the gator region of the leg on this gal right here, 85-year-old, tense blister, bullous pemphigus. And usually in 80-some-year-olds, bullous pemphigus is very benign. Pop the blister, it's kind of fun, and then put some topical antimicrobial on, like a silver, and wrap the leg, and you're just fine. If it's more severe, as in this guy, then you'll have to, the patients are admitted in steroids and all that. Lymphedema finally is no longer an orphan disease. Up until 2024, trying to get resources for these patients was impossible. Now with the Lymphedema Act through Congress, you can get their pumps and their supplies, and it's changed the world of lymphedema, which is really good because we have a lot of patients like this sitting around with, what am I going to do for them? A lot of patients have both venous disease and lymphedema, and that's what I'm showing here. This guy, I had no idea what he had. I biopsied it, it came back nodular, hypertrophic, double backflip. The diagnosis, the pathologist gave me a diagnosis this long, which usually means I have no idea what this is. And I didn't either. Actually, the psychiatrist made the diagnosis, and it's a diagnosis that I see not infrequently. And he's picking at himself. And he thought there was bugs underneath his skin, so he picked all the way down to his calvarium. And it was actually very, very difficult to treat. Now, we have a center in Western Pennsylvania, and you probably have the same problem here. And this 80-some-year-old woman wheeled her 90-year-old husband into the wound clinic and said, "My husband has a moving wound. Make sure you get the head out." But we do see Lyme disease there. And I'm not going to talk much about Lyme disease, but I bring it up because a lot of people use hyperbaric oxygen for that disorder. There's no evidence for that. Have I done it? Yes, I got forced to do it by another surgeon. She insisted that it was going to help her, and she swears to this day it did. She's the only person I ever treated with Lyme. Hopefully, there'll be some clinical trials in the future, and we can take a look at it in case it does work. This is a recessive dystrophic epidermolysis. It's a blistering disease of childhood. The baby's born, and anytime mom goes to move touch the baby or lift the baby, they get like a second-degree burn just because the epidermis does not attach to the dermis normally. And this has been we've been studying these kids for a very long time. I will tell you, when we first started in the late 90s, these kids died before they got their driver's license. Today, I have one that's still alive. She's in her 40s, lives in Buffalo, and is doing well. And a lot of that has to do with all the advanced wound care techniques. I can't go through all of them in one lecture, but all the advances we're using, we've applied it to these kids, and they've done really, really well. We see a lot of traumatic wounds. This is a little gal that was playing on the escalator. Don't let your kids play on the escalator. She has a degloving injury. She did fabulous with hyperbaric oxygen. She got 37 treatments of hyperbaric and then a free flap. Did extremely well. Very nice cosmetic result too. Sometimes we just don't heal the patients. Sometimes we let them. We just treat them based on their symptoms. The guy that you see here. That's that guy that had the 1 centimeter lymph node in his neck, and then they resect it, and it comes back, and he goes to MD Anderson, and they can't do anything for him. And his wife called me, and the problem was, obviously he's going to die. He's got a short life expectancy, but every morning she says this thing bleeds so much that every morning it looks like a murder scene, and he gets anemic, and the ER won't even see him anymore because he's just basically living there. So we brought him into our clinic, and kudos to a Swedish company that gave us some like this real stretchy, soft silicone mesh with antimicrobials in it, and we just wrapped it around his neck, and he didn't suffocate, thank God. And he stopped bleeding, decreased his pain. We weaned off all of his opioids. And he spent the last 3 months of his life driving his tractor around the farm. And that was a huge wound healing success. This is another rare disease we see a lot of, and we also do a lot of study on this as well. This is calciphylaxis, end-stage renal disease in a diabetic with tertiary hyperparathyroidism. It's supposed to be super rare. I don't know. We just finished one clinical trial. We enrolled 78 patients in it. So it's not as rare as we think. But it's an arterial disease caused by the calcium deposits in the skin. It's extraordinarily painful. And we've tried hyperbaric, and we've tried a number of different drugs on it. We haven't really found anything that you can put your head around to say, yeah, that's the treatment for this. We have another NIH grant, hopefully going to start later this year, looking at topical oxygen for these wounds. So I don't do people say, why would you leave vascular surgery to become a wound doctor? Well, I don't do emergencies anymore. Well, I do less emergencies. I don't do aneurysms at 2 a.m. I like that part. But I do occasionally do emergencies. This is Spike. Spike's a Labrador retriever. And my Spike got hit by a car and has a complex wound. And his owner is in his upper 80s. And my friend, the veterinarian, told the owner, hey, look, I'm going to have to put this dog to sleep. And the guy starts crying in the office. So he calls me and says, you got to come down and bring some human medicine for this dog because this guy's crying in my office. And I said, oh, sure. Well, of course not. Now, I will give kudos to the folks at KCI at that time. They gave me a doggy vac. That's a real thing. And so any nurses in the room? Oh, good. All right. So the veterinarian and I are trying to get put this vac on the wound on the dog. And sometimes my nurses, they complain about, oh, it's really hard to get that tegaderm to stick, because it's close to the anus or something like that. I said, try dog hair. That is really tough. So it took us about an hour and a half to get this thing to seal. And of course, if I'd had one of you nurses with me, it probably would have taken a half an hour. Anyway, so we get it to seal. We go into his office. We're having a little drink, and we hear this sound. And Spike is woken up from his anesthesia much earlier than we had anticipated. And we turn around, and he has the KCI foam in his mouth. Only patient that I know of, you may have heard of it, please, if you do, send me a picture. Only patient that I know personally that's eaten the KCI foam. But apparently dogs really like it, because I was doing, have you seen that new wound vac thing, the one that's all one contained? Anyone seen that? That's really cool. So we were playing with that in the office, and my dog went and grabbed it and ran away with the sponge. True story. All right. This is a picture from my phone. I was one of the veterinarians texted it to me. The veterinarians take our hyperbaric course because they want to learn about hyperbaric for horses and dogs, and they've got hyperbaric chambers, little ones, for animals, and that's a thing now. So she sent me this picture. She said, "I remember Spike. I remember that story about Spike, and this is a terrier that had an encounter with a pit bull." She says, "I want to use negative pressure. You got to help me with this." I said, "Well, that looks really dirty." So what we're going to do is we're going to do installation. Now, installation is you, in addition to the wound vac, you put in this case, hypochlorous acid. You put the hypochlorous acid in there, you let it dwell, and then you pull it back out again. Then you put the regular wound vac on them, and they can ambulate normally around the hospital. This is just for inpatients. And then off into the sunset. I don't know why that plays sideways. But you can see it was a really big wound, and it had a very nice result. All right, another wound that we're seeing more and more of is complications associated with plastic surgery procedures that are done outside the U.S. Now, this is a lady from Colombia who went and saw I was going to say plastic surgeon, but that's not what she really saw. It was sort of a taco stand where they inject you. And they take silicone and they inject it mostly in these ladies' buttocks to make it bigger. And you think the taco stand guys go and get at least medical grade silicone? No, they go and they use industrial grade silicone, and they inject this. And what happens is it's a delayed reaction. So about 6 weeks later, it just falls apart. The skin is sub-Q. And by then, the taco stand is in a different city, so they don't catch them. So we published this as part of a part of that approach. But we have seen a lot of patients who go outside the U.S. to get surgery and come back with very interesting disasters. This is another part of the pandemic that's going on. This is the opioid pandemic. The guy this is sent to me from one of our centers in Houston, and I think they're just trying to stop me. They said, "What is this?" I said, "I have no idea. He's got all scarring and open wounds." He was popping, skin popping. So he was taking opioids and injecting them into his skin along his chest wall and abdomen. Why? You're supposed to do it between your fingers, so people can't see it. But and this lady here was at a party, and young gal, she's in her 20s. She was at a party, and she decided it might be a good idea to inject cocaine into her ankle joint. Now, I don't care how good the party is. I would advise against intra-articular cocaine injection. It is a real vasoconstrictor. So she gets this wound. I should put her healed picture in, but she did really, really well. And very complex wound, and with a lot of wound care and hyperbaric, we were able to get it closed. People always ask me about maggots, and we do use maggots. I don't use them a lot, but occasionally we will. This is probably the most interesting case. This is an 85-year-old with recurrent breast cancer, and it's one of those fungating ones. And she's not going to die from her breast cancer. She's going to die of something else. This is it has a very indolent course, but it smells bad, and she wants to go to church. She can't go to church because she has a fungating, foul-smelling tumor. And we tried all of our stuff. Now, the nurses all know this too. We tried honey, we tried charcoal, we tried flagyl, we tried all kinds of stuff. Could not get this thing. So one of my physical therapists said, "Let's put maggots on it." I thought, why not? So we put maggots on. The maggots just ate the fungating tumor. The smell went away. We put some honey on top of that, and she was able to go to church for the remainder of her life. All right, so this is a segmental hemangioma of infancy, and this little gal, Bella, was sent to me after she'd seen the pediatric specialist. These lesions usually go away by the time the kid's 5. When moms would come in with the babies and they have those little lesions, I'd say, come back in 5 years, it'll probably be gone. But this one is growing so rapidly, it's beginning to affect the vision in her left eye. The ophthalmologist says, you got to do something because she's going to lose vision in that eye. So they put her on steroids. You can see the great big jowls. They put her on beta blockers. I sent her to a super laser expert, and he lasered the bejesus out of it. And he sent her back to me on a note from his office and said, debride this, Tom, and send her back. I want her to laser it again. Now, I'm a pretty aggressive debrider, but I'm not touching that. She got vessels the size of my finger in there. So we actually were doing a clinical trial at that time using non-contact, non-thermal ultrasound. And we thought, we went to the FDA and said, can we have this as an orphan indication? Sure, we did it every day. And this is a week later, and what you see is it's cleaned up, and we were actually thinking of grafting at this point. We were going to use a artificial graft, not her skin. But she continued to improve. And there she is at 6 weeks, and it's beginning to envolute. There she is at a toddler, 2 years, and then there she is. That's her Facebook post. Now she's 17 now. She hasn't posted on my Facebook in a long time, and she has that one little scar. You can see it pulls her lid down a little bit. She's had the reconstructive surgery since then. I don't have a follow-up picture. Why is this so interesting? And it's because a lot of what we use, the wound vac we talked about, and this ultrasound, they're physical energy. There's a whole lecture just on the physical energy that we can use to stimulate wound healing. And there's a reason, really a scientific reason that these modalities work so well. All right, anyone done home health? This is my home health slide. So as I said, we have nurse practitioners that go into the home. We oversee about 20 of them. And they're always telling me stories. Oh, you know why Mr. Jones won't heal? Because there's rats running around the place. So I had to have my story for home health, and this is it. This is a dolphin, as you can tell. And I was a water park in Florida. They asked me not to give the name because animal activists and all called me and said, we have done everything to get this dolphin to heal this wound, and we can't get it to heal. Would you come down and help us with it? I said, sure. Sounds like a challenge. So you might be able to figure out where we were. So this is how you debride a wound in a dolphin. They swim into this little cage. They bring that white thing up. All the water falls through it. And then when I jump down onto that white grate, I get this smell of chlorine. And I turned to the vet and I said, is this chlorinated water? And he said, yeah, GCP rule XYZ. It splashes on kids and stuff. So you have to have it. There has to be a certain level of chlorine. I said, well, that's why I won't heal. I said, chlorine is bad for all mammalians. All mammalian fibroblasts cannot operate in a high chlorine environment. It's very, very toxic. So we did inject it with some human growth factors, which probably didn't work. But what really worked is they put the dolphin in a little dolphin rehab without the chlorine, and he healed up. All right, so this is truly a COVID wound. COVID was did a fascinating thing. I don't know how many of you saw this as well with clotting. And this is a disease that I had seen when I was in my vascular training. It's called phlegmasia cerulodolens, when all of the veins in your leg are clotted. Everything, and the leg starts dying. So you see, we did a fasciotomy, and this is just related to the clotting that we saw associated with the spike protein. Whether you got a vaccine and it was worse if you got the disease itself. Fascinating stuff. All right, so we do work all over the world, and I'll share one more story, and then I'm actually going to tell some facts. Otherwise, they'll get mad at me at the CME committee. This is a large part of our practice. I really like this part of my practice. Once a year, we'll spend a week somewhere in the world helping out with wound care because lots of wounds across the world. And this is my one story. Didn't expect that at a wound lecture, did you? All right, so I'm sitting in my living room. Phone rings. Hello? Is this Dr. Serena? Yeah. Are you the wound doctor? Well, I guess you could call me the wound doctor. That's kind of what I am. Did you write so-and-so paper published in this journal? I said, yeah, that's me. And who is this? She says, I'm so-and-so, and I'm the secretary to the Minister of Health for the government of Rwanda, Dr. Agnes Bingawangu. I'm like, sure you are. I'm thinking this is one of my friends playing a prank, for sure. And so I said, put Agnes on the phone. 2 minutes later, Agnes Bingawangu gets on the phone. She's a pediatrician trained at Dartmouth. She's now the minister. She's been the Minister of Health for 20 years in Rwanda. She says, Tom, I want to hire you as a consultant. I said, wow, that sounds great. At first I thought, they had the genocide there. Maybe there's chronic wounds from that. And then I thought, no, the mountain gorillas have problems with wounds. I'm going to go Jane Goodall here. This is going to be great. Agnes says, no, Tom, the gorillas are just fine. She says, Paul Kagame, premier of Rwanda, wants all the men in Rwanda circumcised in the next 2 years, some 5-6 million men. I said, oh, Agnes, wrong doctor. I said, but I have a really good friend who's like super famous urologist from Manhattan. I mean, writes all kinds of papers and everything else. She says, I have lots of your urology people on my board. I need someone that understands foreskin. And apparently, you're the expert. Well, how did they get that idea? Well, because there's a product that's made from foreskin. We take human foreskin and we make wound product out of it. It's called Apligraft. Nothing to disclose. I don't want to stock or anything. And so I'd written a whole bunch of papers. I'd done their clinical trials on Apligraft. So they thought I was an expert in foreskin. But I said, I think I can solve your problem. They were using like a pediatric bell. They were putting it's a double ring system that was invented by the Israelis. Can't make this up. And then there's like a rubber band thing that goes in between the two rings. And then they were using like a pediatric bell, waiting for it to fall off. You can't do that in adult males. It's a mess. And those pictures, I can't show you. I can't look. I don't like looking at myself. So I said, oh, no, we can solve this problem for you. So 2 weeks later, I was in Kigali, and we were circumcising mostly military guys who volunteered for this procedure, and we actually got the procedure really fine-tuned, and we invented a scissor that at 7 days you put the scissor in there and you take the eschar off and it comes right off, and they do really well. I was given orders by Agnes, and she said you can give them 1 Tylenol for the procedure and you can have no open wounds or bleeding. So it was really a challenge. She said, we're going to do this in the bush. So a great project. And they've now, I think they're at 500,000 men circumcised now in Rwanda. Any idea why? Anybody? Other than this was really a lot of fun. I got to tell you, it was a lot of fun. So the Gates Foundation eventually got involved. Right as I was kind of sunsetting out of this project, the Gates Foundation and they predicted if we could circumcise all the men in sub-Saharan Africa from all the way over from Ethiopia all the way across, that the world's AIDS incidence would go down by 60%. Don't know what God was thinking, but apparently when he made foreskin, he put a lot of T cells in it. In fact, in your skin, there's more T cells in foreskin than any other skin in your body. So if you want to transmit AIDS, then a good way to do it is to be uncircumcised. So that was the reasoning behind Kagame and Bingwangu's project. Anyway, thought I'd share that with you. All right, we're getting older. That's my grandma, not the Vogue one, but the other one is my grandma. She died at 106. And I love this Vogue magazine. This gal is 100 years old. So it's beautiful. If you look at this, as we age, we are more likely to get wounds. Last year was the year of the 65s. More people turned 65 in 2024 than ever before. And 16.4% of all Medicare beneficiaries have a hard-to-heal wound. Let me put that in perspective. That's 10 times the incidence of all cancers combined. This problem has a reach far greater than most of the problems that we deal with. And no one knows about it except Medicare. Medicare knows about it because they're spending so much money. And it's costing them an absolute fortune to take care of wounds. So it's a big problem. I spend half my days lobbying anymore than anything else. In addition, the diabetes is also on the rise, and the most common complication of diabetes, my students always say renal failure. No, the most common complication of diabetes is an infected diabetic foot ulcer, and this is rising. And it affects a population. Now, I actually got the opportunity to speak in front of the Senate Finance Committee in 2021, and I led with this slide because I said, you should spend more money on wounds. You should invest more because the populations, the vulnerable populations that you're so concerned about, rightfully so, are the ones that get wounds. Native Americans, and we do research in the IHS, and Hispanics, African Americans. These are the people that get wounds. And so the aging, add to this the aging. This was they didn't give us any more money, but at least they listened. I got my 15 minutes. And not only that, they have a lot of other risk factors. The average patient who walks in the wound clinic has 10 comorbidities. They're sick. All right. I said Medicare knows about this problem. They understand it pretty well. So this is a great paper. Well, I'll let Dr. Evil tell you actually how much they're spending.
$100 billion.
Didn't go to Evil Medical School for nothing. All right. So Medicare spending almost $100 billion a year in chronic wound care, and that is going up exponentially. It's faster than the growth of Medicare itself. So this is a big, big focus. What I'm going to do now is I'm going to take a little side tour, and we're going to talk about some of the things we do. And one of them that I've been involved here at Mary Greeley working with is hyperbaric medicine. Again, I've been doing this for a very long time, and I want to explain a little about it, because the problem with hyperbaric really is that if you Google it, right? Oh my gosh, you get all kinds. You get the Lyme disease, you get autism, you get all these unbelievable stuff that is very little evidence. But there is very good evidence for what we use it for if used correctly. So what is hyperbaric? Hyperbaric is 100% oxygen in a confined chamber and pressurized typically to 2 or 2.5 atmospheres. The treatment lasts about 90 minutes, and your PaO2, the dissolved oxygen in your blood, will go from your PaO2 of 70 or 80 to well over 2,000. It delivers an enormous amount of oxygen. And that does two things. Well, it does more than two, but two main things. One is it drives angiogenesis, and not so much because we oxygenate the wound, but you oxygenate the tissue around the wound. And angiogenesis is driven by an oxygen gradient from high levels of oxygen to low. And the higher you make the gradient, the more you drive angiogenesis. So this is mechanism number one, is that by increasing the oxygen tension around the wound, you drive blood vessel growth into the wound. The second one is really a fascinating phenomenon, and that is diabetics, elderly people with lots of comorbidities, they stop producing nitric oxide in their bone marrow. And that's a real problem. If you don't produce nitric oxide in your bone marrow, your stem cell production goes down, and you can't release stem cells. And this has been well categorized in both humans and animals. Hyperbaric does an interesting thing. It stimulates an enzyme called nitric oxide synthetase. And this has actually been known for a long time. It wasn't until 2010 when Steve Thom figured this part out. So when you do that, when they're in a hyperbaric chamber, they produce more nitric oxide in the bone marrow, they release more stem cells. In particular, the ones we're concerned about are those purple ones called EPCs, which are endothelial progenitor cells. And those cells go to the site of the wound and make new blood vessels. So these are two mechanisms by which we drive angiogenesis into the wound. So if you're trying to decide, is this patient a good candidate for hyperbaric, my first thought is, do they need angiogenesis? Like a venous leg ulcer we showed you earlier. They need epithelialization. They don't need angiogenesis. Diabetic ulcers, on the other hand, they need angiogenesis. So, and that's how you make your decision on what to do, whether it's angiogenesis or vasculogenesis. So there are 14 approved indications for hyperbaric oxygen therapy. It doesn't mean they're all going to be paid for, but there are 14 indications. Probably one of the most common ones we use it for are severe diabetic foot ulcers called Wagner 3. In other words, deep structures, they've had infection, they require antibiotics, typically surgery as well. And this is a 67-year-old with a Wagner 3 ulcer. He's got a bad Charcot deformity in his foot. And I got to tell you, 20 years ago, we would have counseled this guy an amputation. Today, debridement, intravenous antibiotics, and after 20 treatments, he looks really nice in hyperbaric, and we grafted him, continued hyperbaric, and he's closed. And this has made a big difference in the treatment of these severe diabetic foot ulcers. Now, ideally, I'd like to get to these ulcers before they're Wagner 3s, but for now, that doesn't seem to happen. Diabetic patients always seem to come late, right? They can't feel these ulcers, so they ignore them, and then they go to a stage where they need more advanced therapy. You can select problem wounds is also an indication for hyperbaric. This lady had Coumadin-induced necrosis, and I just tried everything in the wound clinic to get it to heal. Just could not get it to heal. I asked her insurance company if I could put her in hyperbaric because nothing else is working, and she did very well. Probably the best indication for hyperbaric are the adverse effects of radiation. After you have a radiation therapy, there is a microvascular disease that occurs, endarteritis obliterans. In other words, the tissue becomes more and more hypoxic. And I have a friend who's a radiation oncologist, and we were talking about this, and he says, well, you're going to see more cases. I said, I thought you guys were getting better. You don't get all that CT-guided block. He says, no, because the patients are living longer. The patients' survivals have increased. So if they had radiation, they're more likely to have adverse effects of radiation, because the longer it's been since you had radiation, the more likely you are to get an ischemic effect. Everything that radiation does increases fibrosis, decreases cellularity, decreases blood vessel growth. Everything that the late effects of radiation does, hyperbaric reverses. It does the opposite. Drives angiogenesis, decreases scarring, increases cellularity. It's peas and carrots. Osteoid necrosis, the most common. The jaw's in the way, and it doesn't have a great blood supply. So if it gets injured during radiation therapy, hyperbaric oxygen is really now the standard of care. And most of your oral surgeons and dentists will not operate or pull teeth or do dental work without hyperbaric coverage for these patients. Soft tissue radionecrosis, we see a lot of patients who've had the adverse effects of radiation. This lady, we thought this was a pressure ulcer, and then we found out that she had radiation when she was much younger, almost 30 years before that. And this is the entrance site for pelvic radiation. And this was a radiation wound, and it took 90 hyperbaric treatments to get her onto complete closure. Radiation cystitis, hyperbaric is now the standard of care for radiation cystitis as well. The Urology Society has now recognizes this as a primary treatment. It's in their guidelines. If the patients have significant problems with bleeding, hyperbaric oxygen therapy through angiogenesis will help most of these patients. Not all. It's not perfect, but it has a very nice result rate, usually in the 75 to 80% response rate. Similarly, the radiation proctitis, the colorectal surgeons just published their guidelines right before the pandemic, stating that as level 1A evidence for the use of hyperbaric to treat radiation proctitis. We do a lot of this because a lot of these patients we pick up when they come in to the ER with bleeding and they get admitted for transfusion. There's no reason for that. I mean, if you have radiation proctitis, these patients respond very, very well. It's a greater than 80% response rate, and they do well. And in both for cystitis and proctitis, it seems to have a lasting effect. These patients always ask me, "Am I going to have to come in every 3 months?" And the answer is no. Once the angiogenesis is there, unless you have more radiation, it doesn't come back. So generally, it's a one and done treatment, which is nice. Infectious wounds. This is a little kid with a necrotizing fasciitis. We've been using, necrotizing fasciitis has been an indication 30 plus years. The idea being that most of these are anaerobes. You put someone with anaerobes in a high oxygen environment, the anaerobes can't survive, and for the angiogenesis. And again, I mentioned diabetic, but diabetic foot ulcer infection and osteomyelitis, this is a mainstay in wound clinics across the world now, is having hyperbaric oxygen therapy for the treatment of these complex diabetic wounds. Crush injuries and peripheral ischemia, not used all that much anymore for it. We have a clinical trial getting ready to start on acute peripheral ischemia. Obviously, it makes sense. If you have acute peripheral ischemia and they give you lots of oxygen, it should be helpful. The problem is our fault, and that we haven't studied it in any detail. So Medicare now says, well, we want a clinical trial, so we're going to do that. And sometimes you don't need the angiogenesis. You just need lots of oxygen. So if you do a flap or a graft and it's not doing very well, or a thermal burn, and you just need oxygen support for, say, 3 or 4 days, you put the patient in hyperbaric and you deliver a lot of oxygen. And then neurologic indication. This is the brave new world for hyperbaric, I believe. Carbon monoxide poisoning has been around for a long time, and there's a couple less common neurologic indications such as central retinal artery occlusion, which is sudden blindness, and this sudden idiopathic sensory or hearing loss, which is a loss of about 40 decibels of hearing. That's no one exactly knows why. It's probably an ischemic event, but hyperbaric works extraordinarily well for that condition. But it's not all that common. It's there's a lot of interest and research in traumatic brain injury. We've done clinical trials in TBI. The clinical trials need to be done better before we can recommend it. Right now, I don't recommend it for traumatic brain injury, but it is something of interest. All right, let's shift gears from hyperbaric and talk about another thing we use in the wound clinic frequently. When mom is carrying her baby, she actually carries two miracles. The first is the baby, right? The new life. It's wonderful. The second is the placenta. And the placenta is probably one of the most regenerative organs that we have in human exposure. So you can take mom's placenta and you can make 20 to 30 grafts from that placenta, depending how big they are. And those grafts then are sterilized through a process of minimal manipulation, and then you can apply those to diabetic ulcers and venous leg ulcers, and it accelerates wound healing. This is really an interesting advance and a terrific use of something that, you usually throw away. So, and there's now, I think, 21 clinical trials ongoing looking at placental-based tissues of all kinds of varieties on the healing of diabetic venous and pressure ulcers. And this is what they look like. This is just one of them. It kind of comes like, looks like tissue paper, and it helps the wound. Another thing I would just share with you is that another technology that's come out recently that's really kind of fun. And right now it's in wound care, but we're beginning to use it in the surgical suite as well. And the problem with bacteria is you can't see it. So this is a device that shines a purple light, 405 nanometers, on the wound. When you shine that specific wavelength on the wound, the molecules within the bacteria themselves, the porphyrins, they vibrate, and that emits their own light. The AI in the device picks up that light, which is red, and it can tell you when you have more than 10 to the fourth colony-forming units per gram by just taking a picture. This is what it looks like. That's red fluorescence. You see the red around the diabetic. That means there's more than 10 to the fourth colony-forming units per gram in that wound, and that needs to be treated. They need antiseptics. One exception is Pseudomonas. Pseudomonas doesn't have porphyrins. That's another molecule called pyrovaridines, and it gives a cyan. It's got a bright white little cyan color when you see Pseudomonas. This is now FDA approved for detecting Pseudomonas. It's made a big difference in what we're doing in the burn units. All right, so this is from our clinical trial, and I'll just share this real briefly. The way we did it is we took a picture, and then the investigator said, infected or not infected. Oops, sorry about that. Didn't even let us cooked up. All right, that's bizarre. Okay, there we go. I'll put it over here. It must be hooked to my computer somehow. Anyway, this is my patient. I said, that's not infected. Doesn't look infected at all. You see any red? So, and what we learned in this study was that our current way in the wound clinic of detecting clinically significant bacteria is not very good. You can do it by clinical signs and symptoms, but I just showed you clinical signs and symptoms aren't very good. In fact, the accuracy of clinical signs and symptoms in detecting high bacterial loads, 15%. Well, good thing we have cultures. How good are your cultures? Well, I'll tell you, one of my nurse practitioners, she loved to culture wounds. She just loved it. And when I wrote this paper and I looked at the results showing that swab cultures are very inaccurate in chronic wounds, not acute wounds, but chronic wounds. And when I looked at this, when I wrote this paper, I went into the wound clinic, I grabbed all the culture swabs, and I threw them all away. So one day, we're in the clinic with her, and she runs over to her purse, and she grabs it, and she picks it up. She's going in the patient's room, and I knew what she was doing. So I followed her in, and she's getting ready to open up the culture swab, and I said, stop. That culture's $80. I'm going to save us $79.75. I reached in my pocket, I pulled out a quarter. I said, heads will treat for infection, tails we won't. Of course, she knows my dad humor. She rolled her eyes. But I was right. My quarter is more accurate than her swab. So why not just flip a coin and save the money? So this is the reason that we developed and launched now what's called the MolecuLite device. Nothing to disclose our own stock or anything. We also looked at antibiotic prescribing practices, and it turns out, not to do this real quickly, but it turns out that antibiotic prescribing in the wound clinic right now is completely haphazard. Same is true with antimicrobials. When we put this device into our wound centers, the use of antibiotics went down 50%. The exact number is 48% reduction in antibiotic use. Why? Because you can see the bacteria, you can debride it, you can use antiseptics. It's much easier when you can see it. All right. one other thing about this is really interesting. When we did the molecular trials, the fluorescence imaging trials, everybody had to have a what's called a Fitzpatrick score, and it's just a grading of what the color of someone's skin. We did it because you're doing optical physics and you need to know what color the skin is. We didn't do it for any other reason. But when we got it done, we realized that we had everyone's skin tone in the whole trial, 350 patients. So we started looking at it and said, how accurate is it depending on your skin tones? Well, it turns out if you have a dark skin tone, Fitzpatrick 5 or 6, the ability of a clinician to detect a clinically significant bacterial load is almost zero. It's 2.9%. And fluorescence imaging increases that dramatically. And now this one guy up here is one of my patients. You can see there's no way, still today, you can convince me that's infected. But it's really infected. It's very, very difficult to see bacteria in dark-skinned individuals. And this device has really changed the way that we've done business. All right, last little part. Now, I've got to disclose, this is not FDA approved. So this is off-label. We're just getting ready to send this product to the FDA. It is approved in Italy, which is where I got my experience with it. It's an acid, methane sulfonic acid. So the guy who invented this, guy named Carlos from Milan, is a great guy, but I don't have any idea how we ever come up with this idea. We're going to throw acid on the wound. Well, that sounds like a great idea. But what it does is it desiccates it. It removes the water. Biofilms, which are really a problem in chronic wounds, are 97% water. So if you smear this stuff on, the dead tissue and the biofilms get desiccated by this agent. I'll just share a case with you. You can see pre-treatment, pretty bad-looking wound. When you take the fluorescence image, lots of bacteria. 1 60-second application of this acid. You put it on, you wait 60 seconds, you wipe it off, and it looks like I did it with a knife, and the fluorescence is gone. Wow. This is really amazing stuff. There's a week later. And the biofilm stays gone for some reason. I don't understand that yet. All right. So that one's just heading towards clinical trials in the near future. Maybe Mary Greeley in the wound clinic will participate in the trial. All right. I'm done. Thank you very much. But we have 3 minutes for questions if you like. Comments. Yes. Oh, great question. So does hyperbaric oxygen increase the growth of malignancies? We studied that it was about 15 years ago. We studied it pretty heavily because we were worried. Hyperbaric oxygen drives angiogenesis. Cancers grow by secreting mostly VEGF in order to hijack your vessels and cause angiogenesis. They can't grow without it. So we looked at all the animal studies, we looked at all the clinical studies, and there is no evidence that hyperbaric increases cancer growth or causes cancer. And that's been well studied because we worried about it a lot in the early days. The reason probably is the mechanism. If you have a cancer, then it's producing growth factors at an uncontrolled rate. You have uncontrolled cell growth. Hyperbaric's not going to make it produce more uncontrolled cell growth than it already does. Yes. Great. All right. So the physician's training is a 40-hour course. It goes over the basic principles of hyperbaric and goes over each of the indications. And then we teach the course too, but we also take a chamber apart and put it back together, and you get to see the inner workings, which is really a lot of fun. So the 40-hour course is what the physician needs. Some hospitals also require some proctoring. We do that online, so it doesn't matter. So for the physician piece, it's pretty easy, but hyperbaric oxygen has a very, very low complication rate. I mean, it's incredibly low. And so it's almost like being anesthesia, right? You're just there in case there's something goes wrong. It almost never goes wrong. For the tech also takes the course and typically the tech is also proctored as well. And then we provide support to that tech. The tech operates the chamber, and they need to be able to prove to our team that if we're working with them, that they are competent in operating the chamber. And then after they've worked in this unit for a couple of years, we encourage them to get certified. Now, you need 480 hours at chamber side before you can get your certification, so you just can't go and get it. But that's the tech. The tech really does all the work. The docs, you're just there in case you're needed. But again, the most common complication, ear barotrauma, which occurs in, roughly 30 out of every 10,000 treatments. And then the other complications are really rare, like seizures and pneumothorax, things like that. Those are super rare. And in fact, I always tell everyone, if you see one, take a picture of it because I need it for my slides because they're so rare. We could do one more. Well, if not, then any more online? Amber? Okay, well, thank you very much for hosting this. It's been terrific. And you're more than welcome to contact me later if you like. Thank you.